Today we're going to be talking about 5 things that you need to know if you're dealing with a meniscus injury. And no, just because you have what is called a meniscus tear doesn't mean that you are destined for surgery. You can still recover without surgery. We're going to give you a better indication of what those circumstances might be in today's video, as well as some guiding principles to help you make that decision. Now, I myself like to group these into basically 3 categories. So you have athletic traumatic, you have non-traumatic, and then you have more of a degenerative issue with the meniscus. Now, those 3 are not medical terms. They're just my way of categorizing things, which I think makes it easier to both learn and understand the issue. We'll get into some of the more medical terms here in just a moment. Now, I'm not a huge fan of most of the images, frankly, any of the images about meniscus tears online, because they all seem very traumatic, very destined for surgery, very poor outcome-ish when it relates to these images. So don't take the image for what it looks like, face value, because most of the tears that you hear about or will see on MRI are not going to be near this significant. Now, the first thing to note is that where the meniscus tear is located at is going to be a big part of the role in how quickly the recovery takes place, both from a surgery and non-surgical standpoint. If you have something, what is called a flap tear, so there's like a bucket handle tear, there's a horizontal flap tear, there's a vertical flap tear. These are more concerning. These are probably in need of surgery. What you are going to likely feel in these instances is a very distinct catch in the knee getting caught as you try to bend or extend your knee. It's like the knee gets locked, and then it's very painful for it to cut loose. It's not like a crack your knuckle sort of pressure releasing that allows the motion to occur again. It's a very distinct catch, and it's very painful. It's like a locking mechanism where the knee just sort of seizes up. These are necessary of surgery pretty much all the time. But if you're not getting any of that catching or locking mechanism, then I really wouldn't be concerned about that. The next thing is where the meniscus tear is located at. So there's the outer portion of the meniscus and there's the inner portion of the meniscus. The inner portion has less blood supply. There's less likely of this one is going to heal. And depending on the significant or the size of the tear, again, you may need surgery. The outside, there's a lot larger amount of blood supply to this portion of the meniscus. Often does well with non-surgical approaches. But again, size can be a factor into the recovery and whether you need surgery or whether you don't need surgery. But here's the thing. I don't want you to get caught up on that image or the image of your MRI if you choose to have one. And pain is formed from a multitude of factors, not just one thing. And as a result, your pain and limitation in function does not correlate one-to-one exactly with what the findings of an MRI are. So an MRI can be useful, but it's also important to pair that with physical findings. And I'd argue that physical findings are even more important in your consideration of if you need surgery or if you don't need surgery. So getting back to these 5 principles, first up is your desensitization stage. This stage, it's often important to do isometrics, because the more you go through a full range of motion, the more likely you're going to bump into some knee sensitivity. So depending on where that tear is located, whether it's the anterior portion of the meniscus or the posterior portion of the meniscus, you're going to have different sensations of issues going on. So if it's in the anterior portion of the meniscus, usually knee extension, those last like 20 to 30 degrees are uncomfortable for most people. Someone who has a posterior meniscus issue, usually deeper knee bending, something greater than 90 degrees, or as you approach 90 degrees, starts becoming more and more painful for that person. So first up is just being aware of where do you get the pain? Is it as you extend the knee or as the knee starts bending? And this is again why, in my opinion, physical findings are more important, because you can get a clear distinction of where that issue might be occurring at in the meniscus simply by doing physical tests. You don't need an MRI to confirm that. Do you have pain with extension or do you have pain with bending? And you kind of know where the issue is located at. So stage number 1 is isometrics in a pain-free range to help desensitize the area. So if you have pain as you're extending the knee, you're going to do an isometric knee extension and a little bit deeper knee bend, or you're going to do a little bit deeper wall sit. If you have a pain as the knee is bending, then you're going to do a knee extension isometric at like 20 to 30 degrees of knee extension. So a little bit further with the legs straightened, or with the wall sit, you're not going to sit down as low. So just do it where it's comfortable and start there. Now the second phase is a loading phase. So we're still going to utilize the range of motion that's comfortable for you, whether that's a deeper range or a shallower range. And we're going to start actually loading the area up a little bit more, so we desensitize it further with the variable of load. So most of the time this takes the progression of a wall sit. You can still keep doing the wall sit, but it takes the progression of the wall sit to a box squat. Now, oftentimes in the closed chain environment where your feet are on the ground, you don't really have to worry about the top portion of that lift. You just have to be concerned about the depth. So someone who has that posterior meniscus issue, you're gonna have to be really cautious about how deep you go. But someone who has more of an anterior tear where they have trouble with the extension aspect of it, they actually tend to do pretty well with this. Again, you just need to find a load that feels comfortable. So find a weight that feels comfortable for the person, and you're just going to a depth that feels comfortable, but usually that person can sit a little bit deeper into those box squats initially. And you just got to be careful of progressing the load too quickly, as well as the sets and reps too quickly. So I usually start 3 sets of 6 to 10. Start with a very modest weight so you get a baseline level of that. Make sure it feels comfortable 24 hours later, and then repeat 3 times a week or so, and just gradually progress the weight and the sets and reps. So using that 6 to 10 rep range is like a bracket. So when you get up to 3 sets of 10 and that feels comfortable, up the weight, back down to 3 sets of 6, and build it back up to 3 sets of 10 to 12 even. And then just repeat that process through. Box squats are great because you can control the depth by setting the box to a certain height. Another level of load is going to a tap down. So a tap down is a partial range. So again, most of the time is going to be comfortable for people, but you have to be more concerned about with the range of motion or the depth of that. So a lot of times with tap downs, you're starting with something as simple as like 3 inches off the ground, progressing that up in load first before you progress the range of motion up. So again, this is the loading phase. So you could do something like holding 10-pound dumbbells at a 3-inch step, 3 to 6 or 6 to 10 reps, 3 sets. Once 10 gets easy, you up the weight and you back down to 6 reps, and then build up to where you're using about 25 pounds. I've in general found you can hold 25 pounds on either side. Then it's probably time to start upping the inch from a 3-inch step to a 4-inch step. Repeat that process. You may back all the way down to 10 pounds, build 3 sets, 6 to 10 reps up till you get to using 25 pounds again, and then you might go to 5 inches now. I usually don't go any higher than 6 inches with the anterior step down. So that's the loading phase. 2 exercises. Again, there's more that can be useful, obviously, but we have a deeper tier, which is a squat where you're working down deeper. And then we have a tap down, which is more of the top quarter range of the motion. And again, most of the time, the posterior tears have trouble getting deeper. Anterior tears, once the area is desensitized a little bit, usually don't have too much issue with closed chain exercises, so long as you don't do high reps or progress the load too quickly. Third stage is the range of motion stage. So just as we were progressing the range of motion with load gradually, we want to start getting full range of motion of knee extension and knee flexion back. So again, depending on where your tear is at, you might do things such as knee extensions, quad sets, leg raises, and adding ankle weights with these tasks, or you might be doing something such as a child rocker where you're trying to sit deeper and deeper into that range of motion. Just be careful of how many reps you do with that, and gradually increase those reps over time, because now we're trying to improve range of motion and restore full range of motion back to the person's knee and what they're capable of doing. And then 4th stage is pretty much just strength training through a full range of motion. Now the game's really opened up. You should be able to do pretty much any exercise you want to in the gym, and you're just trying to turn this back into more or less fitness at this point in time. Stage 5 is impact training. And so impact training is super important because obviously the meniscus is a shock absorption tool for us. So especially if you're getting involved in athletics, you need to have a progressive impact return strategy. So I like starting out with something simple as just like agility ladder drills or these quick feet on a small box. You can progress that to drop downs off of a box, which then can be progressed to single leg drop downs, and then to eventually a depth jump. Obviously, that was a very quick progression. There may, depending on your circumstances, be a lot more steps that you have to gradually take to get to that point in time. but that's something to consider. One other thing to consider is the range of motion that you go through. So again, a depth jump is pretty small range of motion, so you're only going to have about 20 to 30 degrees of knee bend, versus something like a split squat jump, you're going to get down closer to 90 degrees of knee bend. So again, depending on where that meniscus tear may have been, you want to work into both ranges. Just one you're going to have to be more conservative of versus the other. Okay, so there you have it. The general timelines for these injuries is anywhere from like 6 to 12 weeks. So if things aren't progressing in the correct timeline under that manner, then you might start considering consulting with an orthopedic at that point in time. But if you feel like you're making progress and you see the end in sight within that general time frame, then again, just keep progressing as usual. Again, you might need more specific guidance with this. So if you reach a plateau, or if it feels like there's a big jump in any one of those stages, then again, this is just a quick video to show you these stages and a couple exercises you might choose. There's more things you could be doing, obviously, so don't jump to the conclusion that you absolutely need surgery. But in many instances, you don't need surgery. Now, someone who's trying to get back to athletic play as fast as possible, sometimes, they might not go through this trial phase just to save themselves a couple weeks. But again, you have to determine the risk reward of that, where, if you cut some of the meniscus and you don't have that meniscus there later on in life, that's a consideration that you have to take personally in your decision making. Is an extra 2 weeks of getting back to return to play sooner beneficial from you that regard, as it relates to what the potential circumstances may be later on in life? That's a decision you have to answer yourself. There's not clear evidence pointing either direction, so that's something that you can decide yourself. And then finally, one thing I didn't touch on this video is the degenerative meniscus issue. I think we'll probably need to do a separate video on that, because that is totally different than what we were discussing here today. Many times I won't recommend surgery for that issue, just because the long-term outcomes of that aren't very successful, quite honestly. Process really is the same, just your expectations with this person. Generally, this is an older individual, is just a little bit different as far as the general guidelines, the time frames, and what exercises you might choose for that individual based on their previous medical history and current capabilities. So if that video is of interest to you, make sure you comment down below so that I know to make that in the future. If you're dealing with any sort of issue currently, be sure to subscribe to the channel so you get updates of any videos in the future. But also down in the description below, we have video to some workout plans that you can follow, as well as consult with me online personally if you want to have access. There's a link to my schedule where you can schedule a time with me where we can go over your issues, your concerns, and start game planning what you can do to help get you out of pain and back to doing what you love.